Welcome to Section 88. I'm your senior medical examiner today, and this explainer is a high-stakes clinical audit. Look, we're not here to review basic anatomy or casually browse through textbook pathology. We are here for an uncompromised, zero-filler focus on the exact execution traps that cost patients their vision and cost clinicians their licenses. So I expect your absolute attention. Let's get to work. Here's your itinerary for this audit. We'll hit the clinical audit, Trap 1 covering IOP crises, Trap 2 on vascular events, and Trap 3 on infections. After that, we'll test your reflexes in the validation drill and wrap it all up with the executional pearl. All right, Module 1, Intraocular Pressure Crises. Picture this. You're on shift, and a patient walks in with a sudden, incredibly painful, severely red eye. They've got blurred vision and a pounding headache. Now, reacting without precision here, that's exactly how you fall into the trap. Welcome to the 50-50 dilemma. On the judge's bench today, we're pitting acute angle closure glaucoma, AACG, against acute anterior uveitis, also known as iritis. The major clinical trap is seeing that severely injected painful eye and just assuming it warrants immediate pressure-lowering drops, or conversely, aggressive dilation. You absolutely cannot guess here. We demand a strict audit of the specific metrics before you make a single move. So what's the tipping point? It comes down to pupillary geometry and exact intraocular pressure. Those are your defining metrics. AACG is going to show you a fixed, mid-dilated pupil, a shallow anterior chamber, and an IOP frequently pushing way past a staggering 50 millimeters of mercury. Contrast that with anterior uveitis. There you'll find a constricted, irregular pupil, usually secondary to posterior synechia, with a normal chamber depth and a normal or frankly even low intraocular pressure. Now, in a high-pressure environment, you've got to be ruthless about separating the noise from the true signal. You know what the noise is here? Nausea, vomiting, abdominal pain. In an IOP crisis, these systemic symptoms can frequently mimic an acute abdomen, completely distracting an unwary provider from the actual primary ocular driver. Do not get distracted. The true signal you're auditing for is a cloudy, steamy cornea paired with a hard, stony eyeball on palpation. That right there is your undeniable signal of an acute angle closure crisis. Which brilliantly illustrates the fatal error in this scenario. We literally call it the dumb mistake. If you misread the signs and administer a mydriatic pupillary dilator, like atropine, to a patient with undiagnosed AACG, you will completely seal off the trabecular meshwork. This directly prevents the drainage of aqueous humor and accelerates permanent optic nerve ischemia. You are quite literally locking the exit doors during a fire. Just don't do it. Moving on to Module 2, Retinal Vascular Accidents. Let's shift gears to sudden, painless, unilateral vision loss. Challenge yourself to identify this fundoscopic landscape. What you're seeing are these stark visual tipping points of vascular architecture right side by side. Central retinal artery occlusion, or CRAO, versus central retinal vein occlusion, or CRVO. Both present with painless vision loss, sure, but their underlying pathology and their visual signatures are entirely distinct. Let's decode what we're looking at. CRAO represents an embolic ischemic stroke of the retina. The fundoscopy is going to show a pale, ischemic, whitened retina with a really prominent cherry red spot right at the fovea. Honestly, the retinal arteries might even look totally bloodless. CRVO, on the other hand, represents a thrombotic venous outflow obstruction. Its classic appearance is what we call blood in thunder: extensive retinal hemorrhages, tortuous veins, a swollen optic disc, and macular edema. Simply put, one is a severe lack of inflow, and the other is a catastrophic blockage of outflow. Next up, Module 3, Periorbital Infections. Okay, we need to establish the exact management threshold for soft tissue tracking. I'll ask you point blank, what singular physical exam finding dictates whether a patient goes home with an oral prescription or goes straight to emergency surgery? The deciding factor is extraocular muscle impairment and proptosis. Restricted eye movements, diplopia, and decreased visual acuity, those are your ultimate red flags confirming that the infection has officially breached the orbital septum. Let's see how this escalates chronologically based on severity. If motility is completely intact and there's absolutely no pain with eye movement, you're likely dealing with a preseptal profile. The intervention? Oral antibiotics like amoxicillin clavulanate and strict outpatient tracking. But the absolute second you detect impaired motility, proptosis, or pain with gaze, the protocol escalates violently. You mandate an immediate hospital admission, a stat CT scan of the orbits, and IV vancomycin paired with ceftriaxone. No exceptions.
And here is the absolute red line threshold in our pathology variance backs the surgical threat. If the patient has a subperiosteal abscess that just isn't responding to your IV therapy, or if you note a worsening relative afferent pupillary defect, medical management has officially failed. This scenario demands emergency surgical debridement and orbital decompression to save that eye and, critically, to prevent intracranial spread.
All right, it's time for the mandatory validation drill. Let's test your reflexes.
You've got the parameters, so let's see some real-world application. Here is your first Socratic challenge. A 62-year-old female presents with sudden, severe right eye pain, blurry vision, and vomiting. This all started while she was watching a movie in a dark theater. Your exam reveals a ciliary flush, a mid-dilated non-reactive pupil, and a steamy cornea. I need you to synthesize the environmental trigger of a dark theater, the systemic noise of the vomiting, and that pupillary geometry. What's your diagnosis? You should have instantly locked in on acute angle closure glaucoma.
Next vignette. A 74-year-old male with chronic hypertension presents with sudden, painless total vision loss in his left eye. Your fundoscopic exam reveals a diffusely pale, whitened retina with a sharply demarcated red circular area directly in the center of the macula. Identify the pathology. Yup, that's the classic cherry red spot. You are staring down a central retinal artery occlusion.
So let's map those findings onto a real-world ischemia chronology. Recognizing the exact minute on the clock is the ultimate determinant of tissue survival in a CRAO. At minute 0, ischemia begins. And listen to this. The limit of retinal tolerance to complete ischemia is a brutally short 90 to 120 minutes. Beyond that 120-minute mark, you're looking at irreversible, permanent cellular damage, permanent blindness.
Which brings us to our final takeaway, the executional pearl. This brings our clinical audit to its climax. I'm just going to deliver this hard truth with aggressive clarity. The absolute most frequent execution gap regarding painless vision loss is waiting for an ophthalmology consult before attempting rescue maneuvers in a documented CRO. Think back to that timeline we just talked about. The retina tolerates complete ischemia for barely 90 to 120 minutes. If you sit around waiting for the specialist to arrive, you are actively allowing that retina to die on your watch. Delays here are completely 100% catastrophic. You have got to execute uncompromising rescue maneuvers immediately to lower that intraocular pressure, hoping to dislodge the embolus further downstream. Right there, within the emergency department footprint, your immediate actions include performing ocular massage and administering intravenous acetazolamide. You initiate high-flow oxygen. These are steps you take while the consult is being paged, not after they arrive. Which leaves us with this final, somewhat provocative thought to permanently reinforce your Socratic burden of immediate action today. If you lose that critical 90-minute window simply waiting for a consult to walk through the emergency room doors, what exactly are you attempting to salvage? The tissue is already gone. Audit your metrics, strictly separate the signal from the noise, and when the clock is ticking, execute. Class dismissed.